Pelvic inflammatory disease or PID, infection of the upper female reproductive system, including the uterus, fallopian tubes, and ovaries. It can cause a number of serious complications, including infertility. The female reproductive system includes all the internal and external organs that help with reproductions. The internal sex organ are the ovaries, which are the female gnaths, the fallopian tubes, two muscular tubes that connect the ovaries to the uterus, and the uterus, which is a strong muscular sac that the fetus can develop in. The neck of the uterus is called the cervix, and it protrudes into the vagina. At the opening of the vagina are the external sex organs, and these are usually just called the genitals, and they are in the valve regions. They include the labia, the clitoris, and the mons pubis. The vagina, uterus, and fallopian tubes all have a mucosa, which is a layer of epithelial cells that lies inside of these organs. PID usually develop from a bacterial infections in the vagina or cervix, which causes inflammation of the mucosal layer. About 16% of this time, this change of the composition of bacterial flora in the vagina, also called bacterial vaginosis. Because the reproductive tract is essentially well thinner, the sources, ovaries, and outside the external sex organs, the infection can travel up the tract pretty easily. And some mechanism can make it even easier. For example, cervical mucus, which normally acts as a barrier preventing bacteria from entering the uterus, can become less effective. The mucus can become thinner as a result of normal variations throughout the menstrual cycle. Or alternatively, it can become less effective in the context of bacterial vaginosis, which is when the normal balance of vaginal flora is altered and anaerobic bacteria proliferate and degrade the cervical mucus. Other factors contributing an infection may be retrograde menstruations, which is when the menstrual blood flows back through the fallopian tubes and into the pelvic cavity instead of out of the body, and also sexual intercourse. Now, PID is the most problematic when the infection reaches the fallopian tubes, in which case it's called salpingitis. If it also affects the ovaries, it's called salpingo-oophorytis. The infection triggers a response from the body, which sends in neutrophil, plasma cells, and lymphocytes in the fallopian tube. But this actually damages the tubal epithelium, and the tubes become filled with pus. When scar tissue formed to repair the damaged area with damaged epithelium tend to stick to another, creating closed-off packing and little dead patches in the fallopian tubes. This scar in the fallopian tubes can lead to a number of complications related to PID. If pus builds up in the tube and ovary, it can turn into tube-ovarian abscess, which can be life-threatening if it ruptures. If a watery fluid builds up in the packet created by scar tissue and the tubes, this is called hydrosalpinx, and it can cause affected area to become swollen. In general, because of the structural damages it created the fallopian tubes, individuals who have PID tend to have more difficulty getting pregnant and have a higher risk of ectopic pregnancy and chronic pelvic pain. One last complication is Fitzhugh-Curtis syndrome, which occurs when the inflammation from PID expresses peritoneum and forms tear to Gleason's capsule, which surrounds the liver. This results in violent string adhesion or strings to scar tissue that attach the liver to the peritoneum. There are many different bacteria that are associated with PID, but the most common are Neisseria gonorrhea and Chlamydia trachomatis, which is responsible of the sexually transmitted infection gonorrhea and chlamydia. Occasionally, PID can be caused by other forms of bacteria introduced in the reproductive tract by surgery, abortion, or even normal vaginal childbirth. Most of the time, the infection is caused only by one type of bacteria, but in about 16–14%, it becomes polymicrobial. Essentially, the original infection makes it easier for other bacteria to settle into the reproductive tract. Because of relationship with chlamydia and gonorrhea infections, sexually active females, particularly those who have multiple sexual partners and do not use condoms, are the most risk of developing PID. Someone will have few or no symptoms of PID. When there are noticeable symptoms, they include the pelvic pain, tenderness around the ovaries and fallopian tubes, fever, and abnormal vaginal discharge. Diagnosis of PID is usually based on clinical findings, particularly pelvic pain and cervical motion tenderness, which is when mobilizing the cervix during a vaginal exam causes pain or discomfort. Tenderness is the right upper quadrant of the abdomen, is also common if Fitzhugh-Curtis syndrome has developed. There is no specific test for PID, but there are some that can support the diagnostic like testing vaginal discharge for cyanobacterial vaginosis. Doing a nucleic simplification test to look for chlamydia and gonorrhea DNA in sample taken from the inside of vagina or cervix, or doing a laparoscopy of the fallopian tubes. An ultrasound can show if there is a fluid in the fallopian tubes and whether a tube ovarian abscess or hydrosalpinx is present. Treatment involves giving max of intraepithelial usual and injection ceftriaxone or ceftazidime followed by 14 days of oral doxycycline and metronidazole to treat the bacterial infection responsible for PID. Acetaminophen can be given to manage the pain until the antibiotic have treated the infections. Occasionally, surgery will be needed to remove adhesion that or the case pain or the treat complications of PID.